Good afternoon, madam. Good afternoon, everybody. I'd like to thank Priya madam and AOS for giving me this opportunity. So today I'll be talking about IOL placement in case of a compromised posterior capsule. So as we know, posterior capsular rupture is the most common complication during cataract surgery, and the incidence, it varies from 0.2% to 14% from senior surgeons to residents and fellows. So first, I will be talking about PCR when it happens in manual small incision cataract surgery. So what are the options we have when the PCR is very large, when there is not enough support? It is always better to leave the patient aphakic and take the patient for a secondary procedure later on. If there is enough capsular support, then we can place a 3-piece rigid lens or a 3-piece acrylic lens in the sulcus, which is safer. Then we have the iris fixation. If the surgical duration is not much longer, you have 5 minutes, 10 minutes into surgery, you have a large PCR, you don't have enough support, then probably we can go for a iris fixation of the intraocular lens. But at the same time, if the surgical time is prolonged, it's been half an hour or so, or if there is a lot of positive pressure, it is always better to avoid placement of IOL in the first go. And then we have the iris claw lens. So we'll just see about. So, like I said, when do we leave the patient aphakic? Prolonged surgery, no backup IOL available, and not enough support. So, coming to the first part, IOL placement in the sulcus. So, this is a case where there was a large central PCR, and the rhexis margin is very clearly visible. So, gently the leading haptic is placed above the rhexis margin, and the trailing haptic. To place the trailing haptic, it is always better not to dial when we have such a large PCR. It's better to hold the haptic and force it inside and pronate so that you are making sure it does not go inside the capsular rent area. And one other thing is most often when we are having a PCR, when the surgical time is higher or when it's a pseudo exfoliation patient with a PCR, there is one problem of having a small pupil. So whenever we have a small pupil, when we are doing an extracapsular cataract or a manual small incision, so it doesn't matter because you're at the end of surgery. Never hesitate to place iris hooks. No, in manual small incision cataract surgery and ECC, it's always better to use iris hooks rather than using pupil dilating devices like the Malujan ring or the other devices, because the limitation of dilatation is just it's going to be only around 6 millimeters. Whereas with the iris hook, you are going to dilate it even more, and you will have better visibility while placing the intraocular lens. So why is this important? If you are going to do a blind procedure, we are going to, it's a gamble. The chances of having the IOL drop is there. So this is the next one is the IOL Sling Technique by Dr. Manasnath. So when we have a large PCR and we are trying to implant an IOL, there is always a chance that we can drop the intraocular lens into the vitreous cavity, like here. So what Dr. Manasnath suggests to do is he always uses a 10-0 or 9-0 nylon, passes it through the optic, the dialing hole in the optic. He keeps it outside the eye. He gently places it. And when you have this anchoring by the suture, you can also dial the intraocular lens if you are comfortable dialing it. So once it is stable, you can just cut the suture and pull it out. You don't have to remove it totally. So this is a safe way. Even if you drop the intraocular lens, you can always lift it back. So this is a safe tip from Dr. Manas. And then comes the iris claw lens. So the iris claw lens, so little bit of wet lab practice and with the proper instruments like the iris claw holding forceps, it is easier to place this. The only problem is you should have a big library of lens. You should have all the powers of intraocular, all the powers of this. So in private practice, this is going to be a little difficult. But if you have a case which is problematic, when you think you might need to place an iris claw. It's always better to have one or get it ordered and keep it with you. So iris claw lens, the trick is proper centration. And the biggest disadvantage of this lens is once the enclavation happens, you cannot remove. If you try, so it has to be perfect the first time. There are no second times when you're operating, when you're trying to place an iris claw lens. So you have to exactly position the claws. Otherwise, if it is a little bit tilted, if you want to remove the enclavation, it is going to be this enclavation is going to become very difficult. When you try to pull, you're going to damage the iris, or you're going to even cause an iridodialysis because it's so firmly attached. So if at all you have to remove the iris claw, you might have to use a vitrectomy probe and cut the iris in that area. So you're going to cause a permanent hole in the iris. So this is one surgery which it is always better to practice properly a couple of times before even attempting. And post-operatively, there are chances of having iritis and optic capture is a little bit higher in this technique. So it takes a little bit of time to really understand and do this. So this video I got. And then there is this single haptic fixation of intraocular lens. So when we have a large PCR, so this is a case where superiorly we have a nice capsular support, whereas inferiorly there was a large PCR and vitrectomy was done, and part of the capsule was also removed. After that, a 10-0 proline suture with a long needle is passed from the limbus through the iris and then externalized through the iris and the limbus on the opposite side. And gently the 10-0 proline suture is removed, is pulled out as a loop with the help of a Kublan hook, and then it is looped around the haptic of the IOL. So here the leading haptic is gently placed in the sulcus. The trailing haptic is held, and then the sutures are pulled on the opposite side so that it becomes taut around the haptic. So if you don't do this step, there are chances the suture loops will come out and there won't be proper centration. You can have IOL tilting post-operative. So it's very important. And once that is done, you internalize. You trim the suture outside, bring it inside the anterior chamber, and through the common paracentesis made in between, you externalize both the sutures and tie them up. So this is a very easy procedure compared to, it is a easy procedure and it can be done as a primary procedure. That is the biggest advantage of doing a single haptic. So when you have a large PCR, the centration is very good. But in double haptic fixation, with experience, it will be good. But there are chances of tilting. With single haptic, you are visibly seeing how the IOL is. So this is a little bit easier procedure. And then coming to phacoemulsification with the PCR. So the options are you place the intraocular lens in the sulcus, or you can place an intraocular lens with the reverse optic capture, pushing it within the bag, and then posterior capsular curvilinear rhexis and IOL in the back and IOL implantation. So first important thing is do not do a wound assisted IOL injection when you have So I use a 2.2 incision. So most of my IOL injection is wound assisted. So when you have a PCR, extend the wound. This is one major. You should not cause any pressure. You shouldn't force the eye or squeeze the eye because you have an exposed vitreous and all that. So make sure you extend to 2.8 or 3 millimeter. Make sure you're comfortable and gently inject. And then the other thing, the same, like I said in SICS, always don't hesitate, even at the end of surgery. Make sure you use iris hooks, have a proper visualization. So iris hooks are actually very good when you have a PCR. You can you have a very large pupil. You can see where the cortex is, where the PCR is. You can visualize the vitreous very carefully also, and then gently you can inject the 3-piece intraocular foldable acrylic lens in the sulcus area and do an optic capture. So this is one tricky thing that a lot of beginners face, in injecting the 3-piece intraocular lens. Most of them come with a screw type injector. So while injecting, it's always important the screw rotates to clockwise direction. At the same time, you keep your cartridge onto the right side And as you screw and the IOL is being injected, you have to go anti-clockwise with your cartridge. So otherwise, what will happen is the IOL will start somersaulting inside. It can cause rupturing the available support, and the chances of IOL dropping is also very high. So it's very important to practice this before doing it. And the other thing is posterior capsulorhexis. When you have a small posterior capsular rent, it's always better to do a posterior capsulorhexis, and then you can place the intraocular lens in the back. This is by Dr. Frederick. This video is by Dr. Frederick.